Good day, everyone, and welcome to my presentation on PD-L1 testing. This is my disclosure slide. Of note, MSD, the manufacturers of pembrolizumab, sponsored me to attend a course on PD-L1 interpretation. Just to give you a quick overview of what I would like to present in this lecture, I'll start with a very short case report, then give an overview of the basic science behind PD-1, PD-L1 inhibitor therapy, discuss the indications for PD-L1 testing, discuss the challenges in setting up PD-L1 testing in the pathology lab, and finally, discuss how to interpret and score PD-L1 immunohistochemistry. We'll start with a short case report. This gentleman is former American President Jimmy Carter. In August 2015, he was diagnosed with metastatic melanoma to the liver and brain. He was treated with surgery and radiation, followed by pembrolizumab, an anti-PD-1 inhibitor. In December 2015, there was no evidence of melanoma on imaging. I haven't checked this morning, but I believe he's still alive today at 96. What this case report illustrates for me is that immune checkpoint inhibitor immunotherapy can offer hope to cancer patients where, medically speaking, the situation would previously have been considered hopeless. Let's take a look at the basic science behind PD-1, PD-L1 inhibitor therapy. In cancer treatment, we are trying to exploit the characteristics of cancer cells that make them different from normal cells, and then target these differences. One of these characteristics is the ability of the cancer cells to evade destruction by the immune system. If we can block the ways in which the cancer cells evade the immune system, we can help the immune system to destroy the cancer cells, and this is called immunotherapy. The PD-1, PD-L1 axis is one such a mechanism that can be targeted with monoclonal antibody drugs. Under normal circumstances, expression of programmed cell death ligand 1 or PD-L1 by normal cells inactivates cytotoxic T cells to prevent tissue damage. This is, for example, one of the mechanisms that enables tolerance of placental tissue by the maternal immune system. Unfortunately, malignant tumor cells can also use this mechanism to inactivate cytotoxic T lymphocytes and to evade elimination by the immune system. By blocking the interaction between PD-1 on the T lymphocyte and PD-L1 on the tumor cell, we can allow the cytotoxic T lymphocyte to remain active and destroy the malignant tumor cell. PD-1 or PD-L1 can be targeted to achieve this block, and several monoclonal antibody drugs with difficult to pronounce names have already been developed. As far as I know, only pembrolizumab, an anti-PD-1 monoclonal antibody, and atezolizumab, an anti-PD-L1 monoclonal antibody, have been registered for clinical use in South Africa. What I have shown to you in the previous slides is actually a gross oversimplification of the role of PD-1, PD-L1 axis in the tumor microenvironment. And as you can see from this diagram, the PD-1, PD-L1 axis plays a role in that interaction between many different immune cells, including between CD8 cytotoxic T lymphocytes and tumor-associated fibroblasts. There are also several other actors beside PD-1 and PD-L1 that play a role in either stimulating or inhibiting T cells. But nevertheless, this axis has been shown to be an important target for drug therapy. For the purpose of this lecture, the emphasis is on predictive PD-L1 testing in a variety of tumor types. PD-L1 immunohistochemistry may also be used as a pure diagnostic test in the workup of trophoblastic disease and certain lymphomas. Immune checkpoint inhibitors have received FDA approval for the treatment of a wide variety of malignant neoplasms, as you can see listed here. This diagram is from an article published in March 2020, and it's already outdated. Additional indications that have now also been FDA approved include pleural mesothelioma, cutaneous squamous cell carcinoma, and basal cell carcinoma, colorectal carcinoma, esophageal carcinoma, and any solid tumor with a high mutational burden. What I would like to demonstrate with this slide is that for several of the indications and drugs listed, and I've just listed some of them, a companion diagnostic assay or complementary diagnostic assay is available. A companion diagnostic assay is defined by the FDA as a medical device, often an in vitro device, which provides information that is essential for the safe and effective use of a corresponding drug or biological product. The test helps a healthcare professional determine whether a particular therapeutic product's benefits to a specific patient will outweigh any potential serious side effects or risks. Testing is mandatory before a specific patient can get access to the drug. An example of a companion diagnostic test that is well known to us is HER2 testing for Herceptin therapy in breast and gastric cancer. A complementary diagnostic is a test that aids in the benefit-risk decision-making about the use of a therapeutic product, but testing is not mandatory for a patient to get access to a drug. For the blocks that are colored yellow and green, the test is typically a companion diagnostic test for first-line treatment and a complementary test for second-line treatment. In South Africa, the PD-L1 testing landscape is not yet as complex as in the US and in Europe. I've taken pembrolizumab as an example. These are the current registered indications for pembrolizumab treatment in South Africa. PD-L1 testing for pembrolizumab use is currently only mandatory for first and second-line therapy for non-small cell lung cancer and first-line treatment of advanced urothelial carcinoma. Although PD-L1 testing is not mandatory for some of the other indications, for example, squamous cell carcinoma of the head and neck, oncologists may still request PD-L1 testing to inform clinical decision-making. The other drug that is registered in South Africa, atezolizumab, like pembrolizumab, is also used for non-small cell lung cancer and advanced urothelial carcinoma, but also for triple-negative breast cancer. Why do we need to test certain tumors for PD-L1? Well, firstly, it has been shown in clinical trials that only a subset of patients with these tumors will respond to and benefit from immunotherapy. By testing for PD-L1, we can predict which patients will have a good chance to respond. A US study published in JAMA Network Open estimated that if FDA-approved checkpoint inhibitor drugs were universally accessible to American patients, the proportion of cancer patients who could be eligible for such drugs would approach 44%, but only 13% will respond to these drugs. Although this percentage seems low, it is much better than oncology drugs in other classes, such as genome-targeted therapies. First-line therapy of advanced urothelial carcinoma is an example of a tumor type where PD-L1 testing is mandatory. In this Kaplan-Meier survival curve of cisplatin-ineligible patients with locally advanced or metastatic urothelial cancer treated by first-line pembrolizumab, the 2-year overall survival was 47% in patients with a PD-L1 combined positive score of 10 or more, and we'll get to what this means, compared to only 24% for patients with a combined positive score of less than 10. Another reason why we cannot, so to speak, just add immune checkpoint inhibitors to the drinking water is because they are associated with a wide range of side effects. We do not want to unnecessarily expose patients to these risks if they do not stand to gain anything from the treatment. Most of these side effects are, as you can expect, autoimmune in nature. The most common adverse effects experienced by patients on immunotherapy are fatigue, pruritus, and diarrhea. And then last, but certainly not the least, immunotherapy is currently prohibitively expensive. I was told that one 3-week cycle of pembrolizumab costs approximately 86,000 Rand, and ideally this should be continued for 2 years or more. This works out to more than 110,000 Rand per month, and this is only for the immunotherapy. Even the top-tier medical aid plans in South Africa require co-payment of 20 to 25% of this treatment cost. From this, it also follows that the cost of PD-L1 testing is a very small fraction of the total treatment cost of a cancer patient, but we have to get this right. PD-L1 immunohistochemistry is a logical choice for a biomarker, but are there any alternative biomarkers to predict response to immunotherapy? High tumor mutational burden, that is defined as more than 10 mutations per megabase, can predict response to immunotherapy regardless of PD-L1 expression. But the best way to test for this is still debated. Several clinical trials have also demonstrated that mismatch repair deficiency, or microsatellite instability high, is significantly associated with long-term immunotherapy-related responses. Both high tumor mutational burden and microsatellite instability high, or mismatch repair protein deficiency, are now FDA-approved indications for the use of immunotherapy. Tumors associated with viral infection may also respond to immunotherapy due to the high antigenicity of these tumors. This is certainly true for Merkel cell carcinoma, but it may also be true for other tumors like Kaposi sarcoma. The interferon gamma release levels could be a biomarker to predict response to immunotherapy in non-small cell lung cancer. There are several other biomarkers under investigation, but for now, PD-L1 immunohistochemistry is still the standard. The next topic for discussion is challenges in setting up PD-L1 testing in the pathology lab. Just to put this into perspective, although there are many challenges in setting up the test, by far the biggest challenge is for our patients to get access to immune checkpoint inhibitor therapy, given the current prohibitive cost of these drugs and the state of public finances. As we have already seen, in many cases, the immune checkpoint inhibitors have been registered for use with companion diagnostics based on the results of clinical trials. In order to say that a test is FDA approved for a specific cancer diagnosis, you need to use a specific PD-L1 clone on a specific automated immunohistochemical platform using a specific scoring system. The Canadian Association of Pathologists call this the 3D approach: a specific drug for a specific disease using a specific diagnostic assay. PD-L1 testing is therefore, unfortunately, not as straightforward as one would imagine. There was no uniformity in PD-L1 assessment among the clinical trials that were performed to approve these agents. A different companion diagnostic antibody clone with associated immunohistochemical platform was used for each approved anti-PD-1 or anti-PD-L1 inhibitor, and it is not always clear how interchangeable these assays are at different scoring thresholds. For example, for these 5 immunotherapy drugs by 5 different companies, they used 5 different PD-L1 antibody clones on 2 different immunohistochemical platforms. On-label use will require using the exact PD-L1 antibody clone on the specific associated staining platform. I think it should now be clear that it's unlikely that one pathology lab will have access to all 5 different PD-L1 clones, and it's even more unlikely that the lab will specifically acquire an entire staining platform just for the purpose of offering PD-L1 testing. As an example, for the first-line treatment of advanced urothelial carcinoma with pembrolizumab, you need to use the 22C3 PD-L1 companion diagnostic assay on a DACO-Link 48 automated immunohistochemistry platform, and the patient's tumor need to score 10 or more on the combined positive scoring system. But if your lab wants to test for PD-L1 for the treatment of triple-negative breast cancer with atezolizumab, you need to use the SP142 kit from Ventana on a benchmark ultra platform and apply the tumor immune cell score on the tumor tissue. I think from this it is clear that it's very unlikely that one lab will be able to offer FDA-approved testing for all the different indications. This brings us to lab-developed tests. This is a test that's developed and validated by a pathology lab with the idea of using this test in the specific lab. These tests are not reviewed or approved by a regulatory agency, and the lab takes the responsibility to ensure that the test performs adequately. So obviously the topic of validation is crucial for a lab-developed test. The definition of validation according to ISO 9000 is the confirmation through the provision of objective evidence that requirements for a specific intended use or application have been fulfilled. There are three spheres of validation: clinical validation, indirect clinical validation, and technical validation. For PD-L1 validation, we need evidence from one red and one blue sphere. When we are dealing with a regulated approved test, the clinical validation has already been done by the manufacturer, and this is the data generated from the clinical trials. For a lab-developed test, indirect clinical validation has to be done. If you want to generate this data yourself, you have to run your proposed lab-developed test and a reference assay that had already been validated on the same set of samples. The guideline is to use 50 positive and 50 negative samples. You then calculate the diagnostic sensitivity and specificity of your lab-developed test in relation to the reference assay. The guidelines state that you should have more than 90% sensitivity and 90% specificity before you can accept that the lab-developed test performs adequately. This is obviously a lot of work, and if you do not reach the required 90% for sensitivity and specificity, you have to start over again and tweak your protocol. Fortunately, you do not have to do this yourself, since a lot of data has already been published in the literature. In other words, you don't have to do the validation with 50 positive and 50 negative samples, but you can simply go to the literature and find out what has worked for them. This paper is a good place to start to look for data on the interchangeability of PD-L1 immunohistochemistry assays. They have collected data from numerous studies to help you choose a candidate assay, and you can then follow the references to get to the specific protocol. And this is another helpful reference if you want to run the 22C3 clone developed for the DACO-Link 48 stainer on a Leica Bond or Ventana Benchmark Ultra platform. Finally, you also need to do the technical validation. That means that you verify that the immunohistochemistry protocol performs as expected in your lab on your tissue samples. Once your test is validated, you obviously also have to do ongoing internal quality assurance, and it's recommended that all labs performing PD-L1 testing should participate in a fit-for-purpose external quality assurance scheme at least every 6 months. Now, I can hear you say, enough of all this technical stuff. Can you please just show us how to interpret and score the PD-L1 immunohistochemistry? And we'll do that just now. There are 3 different scoring systems that are currently used for PD-L1. And the choice of scoring system depends on the specific indication and the specific drug. The tumor proportion score, or TPS, is the number of PD-L1 positive vital tumor cells over the total viable tumor cells expressed as a percentage. This scoring system is similar to the system that we use for the expression of Ki-67. It is typically used for non-small cell lung cancer. The combined positive score, or CPS, is the PD-L1 positive tumor cells plus the PD-L1 positive immune cells over the total viable tumor cells times 100. This is not a percentage, and although the score can be more than 100, it is capped by convention at 100. This scoring system is used in a wide variety of tumor types. The tumor immune cells score is the PD-L1 positive immune cells expressed as a percentage of the tumor area. This score is, for example, used to determine if atezolizumab treatment can be used for triple-negative breast cancer. Let's look into more detail at the combined positive score. Tumor cells are regarded as positive if there is any convincing partial or complete linear membrane staining that is distinct from cytoplasmic staining. Positive immune cells for this purpose includes lymphocytes and macrophages within the tumor or in the adjacent tumor supporting stroma with any amount of membrane or cytoplasmic staining. Plasma cells, neutrophils, and eosinophils are not included. The first step is to select a representative tumor block based on your H&E slide. If you are dealing with a tumor with two or more morphologically different appearing areas, you can select 2 or more blocks, but you will then give an average CPS for all the sections combined. PD-L1 scoring can be done on cell block as long as the cells were fixed in 10% buffered formalin. The minimum number of tumor cells that must be present before CPS can be calculated is 100 tumor cells. You can request additional levels and add all the levels together to get 200 tumor cells if there are fewer than 100 cells on the original section. The entire tumor and tumor stroma on the slide should be evaluated for scoring, not only hotspots as in Ki-67 calculations. Keep in mind that the tumor section can easily contain 100,000 to a few million cells. Exclude areas of necrosis because these areas often show artifactual staining. Evaluation of membrane staining should be performed at no higher than 20 times objective. Remember that the CPS is capped at a maximum of 100. There are different approaches to scoring CPS. The first is structured scoring, where you simply count the tumor and immune cells. This is used in training and in difficult cases close to the cutoff scores. For everyday routine work, categorical scoring is used where the tumor proportion score is estimated and the negative tumor cells are then replaced in your mind by positive immune cells. This approach is suited for obvious positive or negative cases, but an estimated exact score should still be given. Reference scoring refers to comparison to reference pictures in the interpretation manuals, but only a rough estimation is possible with this method. Whole slide imaging and the use of artificial intelligence to do scoring is hopefully something that is not too far away in the future. But the current guidelines still recommend against the use of AI for clinical practice. Let's look at a few examples on how to calculate the CPS. In a tumor section where 10% of the tumor area stains with PD-L1 with a combined positive score of 80, but 90% of the tumor is completely negative, the CPS of the entire tumor area is 10% times 80 equals 8. For urothelial cancer, this is lower than the cutoff of 10, so the clinical interpretation is negative. Note that if KI67 scoring rules were wrongly applied and only the hotspot was scored, the CPS would have been mistakenly reported as 80, which would be interpreted as positive. Let's look at another example. In this case, heterogeneous expression of PD-L1 in a tumor area. For this, we can divide the tumor in 4 equal parts, each with 100 tumor cells. We now count the number of positive tumor cells and add the number of positive immune cells for each area and divide by 100. If we do this, we get 80 plus 30 plus 50 plus 100 equals 260. And if we divide this by 4, we get a CPS of 65. This is more than the cutoff of 10 used for urothelial cancer and is therefore regarded as positive. Let's look at an example where the CPS is close to the cutoff score. In this example, there are 3 tumor cells that show membrane staining and 5 lymphocytes and or macrophages that show membrane or cytoplasmic positivity. The number of tumor cells is 200. The CPS is therefore 5 plus 3 equals 8, divided by 200 times 100 equals 4. This is below the cutoff of 10 for urothelial cancer and is therefore regarded as negative. If this was a specimen from the head and neck area where the cutoff is 1%, it would be regarded as positive. Let's look at the real example. On the left, we have tumor cells, and the overwhelming majority of them show complete or partial membrane staining. While on the right, we have many positive immune cells. If we use the categorical scoring approach, we can start by estimating a tumor proportion score, in this case, plus minus 80%. We can now replace the negative tumor cells with positive immune cells. And I think it's immediately apparent that the CPS will be more than 100. Because the CPS is capped by convention at 100, the CPS is reported as 100 and the interpretation is positive. Just keep in mind that in a real case, the entire tumor and associated tumor stroma on the slide should be scored. I also note that this case would not qualify for interpretation of CPS because there are fewer than 100 tumor cells. This is an example of a case where the tumor cells show no membrane staining, but because there are numerous immune cells that stain positive, the CPS is again close to 100, and the interpretation for this area is again positive. This is an image to show that macrophages, which should be counted as positive tumor immune cells in this case, can look very similar to tumor cells. It is often useful to compare the immunohistochemical stain with the H&E to distinguish tumor cells from macrophages. For this field, the CPS will be 0 plus 12 divided by 53 times 100 equals 22. Just again, remember that the CPS should not be applied when there are fewer than 100 tumor cells. So if this was the total amount of tumor cells, we would have to do additional sections to get to more than 100 tumor cells. This is an example of adenocarcinoma of the lung, stained with SP263 PD-L1 for durvalumab therapy. The tumor proportion score is used, which is simply the percentage of positive tumor cells over the total number of tumor cells. In this example, the tumor proportion score was 70%. This is an example of triple-negative breast cancer for atezolizumab therapy. The tumor immune cell score should be used. If you recall, the tumor immune cell score is the percentage of positive immune cells over the total tumor area. Personally, I have no training or experience with this scoring system, but in this specific example, the immune cell score was estimated as 2%, which is regarded as positive. The cutoff is 1%. Just a few final thoughts. I hope I've given you an overview of the PD-L1 testing landscape, the challenges in implementing PD-L1 testing in the lab, the importance of proper validation, and the difficulties in PD-L1 scoring. This is a relatively new and rapidly developing field where the pathologist often plays a crucial role in rational patient selection for treatment. New technologies like slide imaging with artificial intelligence to score PD-L1 hold the promise of more accurate scoring and better standardization. In addition to these very helpful resources, the companion diagnostic interpretation manuals by the pharmaceutical companies are also invaluable and are available online. Thank you.